Good evening, everybody. I see everybody's kind of filing in. My name is Steve Dave Louie. I'm a dermatologist at Wayne State University in Detroit, Michigan, and happy to be tonight's moderator for our second HS Awareness Week video and from the HS Foundation. And don't worry if you think you missed the first one, we have some that are oriented for physicians and some that are oriented for patients. So this is our first patient-oriented video and webinar of the week, and we're very excited to have everyone here. Learning from our excellent speaker, who I'm happy to introduce, is Dr. Lauren Orenstein. Dr. Orenstein is a dermatologist and assistant professor of dermatology at Emory University in Atlanta, Georgia. She completed dermatology residency at the University of Pennsylvania and received HS specialty training under the mentorship of Dr. Iltifat Hamzavi, former president of the HS Foundation. Dr. Orenstein established the HS Specialty Clinic at Emory in 2019, where her team offers comprehensive medical and surgical management for patients with HS. She subsequently completed a Master of Science in Clinical Research, and her research program focuses on the topic of tonight, pain and quality of life in hidradenitis suppurativa. As I said, I'll be your moderator. So as Dr. Orenstein is talking, if you want to post any questions you have in the chat, I'll be happy to relay those questions to her at the end, and hopefully we'll have a really great session. We're so glad you're here tonight. As I mentioned, there's a couple other sessions this week. So there's another one for physicians tomorrow night, if you want to let your doctor or any doctor that you care about know. And then there's another one for patients on Thursday evening. Check us out on social media. The HS Foundation website is hs-foundation.org, and our social media tags are on there, as well as lots of other super useful information. So without further ado, I'm very happy to pass things over to Dr. Lauren Orenstein.
Thanks so much, Dr. Dave Louie, for the introduction, and thank you to the HS Foundation for the opportunity to talk about this very important topic. I'm excited to interact with all of you in the question and answer session. Before I start, I do want to caveat this with the fact that I'm a dermatologist. I'm not a pain specialist, but I really got interested in this topic because I noticed that it was a big unmet need for a lot of my patients. So I am passionate about helping people get their pain under control. These are my disclosures. And here are the learning objectives. To discuss the impact of pain in HS, review treatment strategies, and then to develop strategies for self-advocacy to address pain. So what is pain? I think we all kind of know, but in a defined sense, it is both a sensory and emotional experience that is unpleasant and is associated with potential tissue damage. The Latin root for comes from pena, which means punishment. What causes HS pain? Well, we're still learning a lot about the causes and the underlying pathophysiology of pain in HS, but a number of factors have been identified. When there's acute inflammation around the hair follicles, there is release of a number of different inflammatory mediators, and those inflammatory mediators activate nociceptors in the cutaneous tissue, which then transducts the sensation of pain through the peripheral and central nervous system. In addition, tissue damage and swelling around the nerves in the skin and damage to those actual nerves. In addition to the actual mediators of the pain or the cytokines that are released and trigger these signals, there are processes as that pain is transmitted, that signal is transmitted through both the peripheral nervous system and then up the spinal cord into the brain. And our normal processes, we have modulation of pain and can kind of tamp down pain response. But in some people who have chronic pain, pain can beget pain. You lose that ability to be able to modulate and tamp down pain, and that can create abnormal feedback loops and sensitization to pain. And then finally, anxiety and depression have been shown to greatly impact the perception of pain as well. So there are likely a lot of different contributors, and we're still learning more about the pathophysiology of pain in HS. Why is this topic important? I think I probably have to convince the clinicians of this more than the patients, but HS has been found to be the most impactful symptom of HS. So pain is more highly correlated with quality of life in people with HS than is even disease severity. Pain can impact a lot of things, physical function, things like reaching for a glass off of a shelf above shoulder level, to mental health and intimacy and relationships. Also, patients with HS are at higher risk than the general population of chronic opioid use, and it's probably this chronic pain that contributes to that. Further, pain is a very important unmet need in a lot of people who are suffering with HS. This is a quote from a patient. Pain management is non-existent despite it having the biggest impact on my quality of life. A lot of dermatologists don't even ask if you're in pain or how you're managing it because it doesn't even occur to them that HS may be painful. And in fact, we do see a very large discrepancy between the importance of pain control for patients with HS compared to providers with HS. So in this graph, in the light gray bar, so both patients and providers were asked, what are the most important attributes or the most important things for you to get out of your HS treatment? And you can see in this light bar that over 80% of patients said that pain reduction was one of the most important things for them, whereas less than 10% of healthcare providers, shown in the dark gray, identified pain reduction as an important aspect of HS therapy. And unfortunately, there are a lot of barriers to patients being able to have their pain addressed for HS. Things like stigma, fear of being seen as a drug seeker, fear of being judged, not being listened to, concern about side effects for medications. Things like, will these medicines cause damage to my organs? Will they make me feel sleepy or not myself? May I get addicted to them? Financial limitations, insurance coverage, and even the time that it takes to see all of the different types of providers that you may need to help address your HS pain. On the other side, there are also a lot of health system and healthcare provider factors that can be barriers to getting appropriate pain management. Problems with being able to access care in a timely fashion during flares. Unfortunately, the response to the opioid crisis has been more punitive than medical, and this is something that we're working on at a national level, but certainly has been a barrier for some people. Practice policy may dictate certain treatment limitations and what individual providers can and cannot prescribe. And then also, unfortunately, structural racism and socioeconomic discrimination are part of our medical system and something that need to be addressed and are being worked on a national level. Finally, healthcare providers themselves. Honestly, especially dermatologists, we're poorly trained in pain management. And so oftentimes it requires, for people with refractory pain, finding the right provider for your pain. So the goal of this talk is really to help give you the tools to help you advocate for pain management. This is not to put blame on patients or to say that you should have to be responsible for this. You shouldn't in a perfect world. But in the world that we live in, we want to help equip you for your medical appointments to help have your pain addressed in an effective way. So some of those important tools are being able to describe your pain, to find the words and the language to tell your doctor what kind of pain you're having and the timing of that pain. To understand some of the treatment modalities that are out there so that you can select the type of doctor that you'd like to see. Setting realistic expectations. and then finding that help that you need. So this is a depiction of a lot of the different types of words that patients in a particular study use to describe their HS pain, with the words that were the most common being the largest and the ones that are the least common being very small. And you can just see through this picture that really people's pain experiences are very diverse, and the way that they experience pain is very diverse. But finding those words is really important, because the types of medications that are offered and recommended by your medical provider may depend on the type of pain. And we can get signals about the type and the mechanism of pain that you're having based on the words that you use to describe that pain. So three kind of big categories of pain type are nociceptive pain, neuropathic pain, and nociplastic pain. Nociceptive pain is the type of pain that comes from something like scraping your knee, or from maybe an acute HS flare. It's caused by damage to the tissue or potential damage to the tissue. And it's often described by people with words like aching, throbbing, gnawing, dull. It's caused by dysfunction within the nervous system. And it's often described a little bit differently by patients. It's often described as being a temperature, like burning or hot, described as stinging, zapping, electrical. So the different words and the language that you use can help providers start getting a clue as to what types of medicine may be most effective for your pain. Nociplastic pain has also been called central sensitization. There aren't necessarily specific language for this, but it's a concept that people may have amplified pain perception because they have more responsiveness within their pain perception pathway. So the percentages that you see here next to each type of pain are the prevalences of each of these types of pain that have been found in HS. About 40% of patients experience some amount of nociceptive pain, about 30% experience some neuropathic pain, and about a third experience some degree of central sensitization or nociplastic pain. So in addition to that pain character, the language that we use to help select treatments for pain, chronicity also may affect your treatment selection. So it's important as you're going into your visits to think, well, am I looking for help for management of my acute pain, or am I looking for management of more chronic pain? Acute pain is defined as sudden onset pain where the cause is clear and the duration is short. One example within HS might be this picture on the left, the patient who is coming into your office who is coming in with a very painful, exquisitely tender abscess that's come up over the last few days. It makes it so they can't even move their arm. An acute pain crisis takes things even a little bit further. It's the sudden change in one's pain where the pain becomes totally intolerable and dominates a person's total experience. Chronic pain is defined, on the other hand, as pain that persists for longer periods of time, typically more than 3 months. Within the context of HS, we might think of chronic pain as being kind of your normal, regular, day-to-day pain that's associated with just the severity of one's disease. For example, this patient shown on the right who just has these chronically inflamed, very painful, draining tunnels under her arms. And this is from an interview study that I'm doing with some of my HS patients, where we talk to them about their pain experience, and demonstrated to me that really those HS flares can become acute pain crises. Patient said, It's very sporadic. It's not a 365-day thing. However, there are very specific times. I can literally tell you the month, the day, and the year that it happened, because every single time it is extraordinarily debilitating. I can't work, I can't do school, I can't function. And every day moving on with my life turns into the worst thing ever. So this doesn't necessarily have to be an everyday kind of thing, but even these acute pain crises, which last for short periods of time, can be incredibly debilitating and stressful. So now let's move to the treatment side of HS pain. And I want to emphasize here that a lot of times managing pain in HS requires a multimodal and even a multidisciplinary approach. In the dermatology office, one of the things that we're often focusing on is optimizing disease control. That is the concept that HS pain management starts with getting the inflammatory disease that is HS under better control and helping you manage that. But in addition to treating the HS pain is often substantial enough that it also needs to be treated. So when we try to treat pain as a symptom, the goals in that are to reduce the suffering that's caused by HS pain, to help restore patients' function, and also minimize the risks of the medications or of the treatments that we're prescribing. And some of the types of treatments that are used for HS pain can be pharmacologic, that is medications, or can be non-pharmacologic, things like psychotherapy, as well as different procedures that can help with pain. So now I just want to get into some of the data that's out there about pain management in HS. There are some published North American HS treatment guidelines from a couple of years ago. And this is what the guidelines say about pain management. They say pain management starts with disease control. Opioids or narcotic medications may be useful for acute pain, so that is short-term pain that's not responding to other things. And incision and drainage, that is kind of opening and making a hole in an HS lesion and letting the fluid drain out, can be helpful for acute or short-term abscesses, but should not be used as the only treatment. So this is all good advice, but it's not very detailed. And the reason is that we really still need a lot more research and data about pain management in HS specifically. But there are some groups, including my own, that have proposed some pain management protocols that are not necessarily based on just evidence from HS, but draw upon evidence of treating other painful inflammatory diseases. So this reflects what is kind of typical standard of care right now is for acute pain, that sometimes you will prescribe topical medications for the pain. This really only tends to help for kind of small and superficial painful bumps. This is not very helpful for areas that have a lot of drainage or really very severe or deep pain. For more moderate pain, standard of care is typically includes things like acetaminophen, non-steroidal anti-inflammatories, which include things like aspirin, ibuprofen, naproxen, steroid injections into the actual HS lesion, and then drainage of big fluid-filled abscesses. After that point, short-acting opioids are sometimes used for short periods of time. And if pain can't be controlled that way, then oftentimes patients need emergency care or care in the hospital. So there are a whole lot of topical analgesics, many of which can be purchased over the counter. These are generally safe as long as used according to the instructions on the package. Although if they're used at high amounts or too frequently, sometimes we can find blood levels of these medications and toxicity from these medications. As I went through that the medicines that are available for acute pain in HS, things like acetaminophen, ibuprofen, naproxen, I did want to just bring up the point that unfortunately, I've noticed that a number of patients who I've seen and taken care of, they perceive over-the-counter pain medications as being universally safe. And so I just want to take a moment to stop and to caution you that even over-the-counter pain medications can be unsafe if they're taken above the maximum dose that's on the bottle or the maximum dose that your provider recommends, or if they're taken for longer periods of time. And I've particularly seen that be an issue with high doses of Tylenol, as well as high doses of those NSAID medications, the ibuprofen and the naproxen. A number of the over-the-counter pain medicines are unsafe if combined with alcohol. And so really the message of this is to talk to your provider, even about your over-the-counter pain medicines that you're using, because the way that you're using them may not be safe if they're not doing a good enough job of controlling your pain. And just a couple words about, in particular, non-steroidal anti-inflammatories, or NSAIDs. Examples of these are things like ibuprofen, naproxen, and high-dose aspirin. Some of the risks of these drugs are that they can cause kidney damage, they can cause GI bleeding, or even heart attacks. And that heart failure is a mistake, heart attacks and strokes. So it's important, if you're taking these medicines over the counter, to realize that they're all part of one family and they really should not be combined. Now moving on to therapies and approaches for treating chronic pain in HS. Starting from the top, chronic pain management will often start with, just like acute pain management, disease-directed therapy. So that's your medicines or your treatments for your HS. There may be some non-pharmacologic or non-medicine things that can be done to help, such as improving kind of the wound care regimen, management of mental health comorbidities, anxiety or depression. In terms of medications, many providers will approach the management of chronic pain by trying to think about what type of chronic pain a patient is having. So this comes back to that language that we were talking about. The nociceptive pain, which is caused by tissue damage and is described often as aching, gnawing, dull, versus neuropathic pain, which is often described as hot, zapping, stinging, burning. So oftentimes in chronic pain, both for HS, and this really draws on evidence from other diseases, NSAIDs and acetaminophen are considered first lines for chronic nociceptive pain. Oftentimes those are insufficient, and so addition of antidepressant medicines like duloxetine or nortriptyline may be used. For the neuropathic pain, though, the first line treatments are actually a little bit different. They're not the NSAIDs and the acetaminophen. It's more anticonvulsant medicines like gabapentin or antidepressants like duloxetine. And then there are a variety of other both medications that are active on the nerves as well as antidepressants that can be used as second line treatments. So just a few words about a few of those specific treatments for chronic HS pain. Data definitely show that opioids are better for pain relief than placebo. But when used for chronic pain, opioids are narcotics. This includes things like oxycodone, hydrocodone, etc. These opioids or narcotics do not outperform the NSAIDs, things like Aleve and ibuprofen. They do not outperform antidepressants, and they also do not outperform anticonvulsants. So given the number of risks that come with opioids, long-term treatment with opioids or monotherapy, meaning treatment with opioids only, is not currently standard of care for chronic pain. And what are those risks? Those risks include things like physical dependence, addiction, worsening depression, cognitive dysfunction, and even unintentional overdose. So while opioids are more effective for chronic pain than placebo, there may be other medicines like these NSAIDs, antidepressants, anticonvulsants that may be safer and similarly effective for chronic HS pain. But opioids may be appropriate for chronic pain in some patients, depending on other medical problems that you have, as well as age. So in those cases, for those select patients, it's really important that you have a provider who is continuously kind of reassessing whether these medicines are effective for you, who are periodically trying to see if they can reduce doses and keep your pain under control. And there are also a few medicines that may be a little bit safer for regular use. Buprenorphine is a mixed agonist and antagonist of the opioid receptor, and so it has a little bit less abuse potential and reduced risk of respiratory depression. And tramadol may also be a little bit safer than some of the other opioids, but really should not be used for patients who are over 65, and it may be unsafe to combine with some other antidepressants that also increase serotonin levels. Medical cannabis. We don't have any data for this in HS, but there may be a role for it if data pan out in the future. It's shown promising evidence for neuropathic pain, for muscle spasticity. Medical cannabis can help with itching, and overall is less risky than long-term opioids. It also has antioxidant and anti-inflammatory properties. But some of the problems or barriers to widespread adoption are there's no evidence in HS. There's not really, because it's not FDA approved, there's not clear dosing or quality controls. There is a risk of dependence. And then it can also interact with a lot of other medications. So this is a consideration, but if you were going to do this, it would be important to do it in conjunction with a provider who had some expertise in helping manage this. In addition to medications, psychological therapy is also very effective for chronic pain. We've mentioned before that depression and anxiety affect the way that people perceive pain, but there's also a very robust evidence base showing that psychological therapy improves chronic pain and helps people also begin to distinguish between the pain and the suffering that they experience because of the pain. So it's two types of therapy that have very strong evidence in other chronic painful diseases are cognitive behavioral therapy and acceptance commitment therapy. Cognitive behavioral therapy consists of kind of a limited number of sessions, and it helps the individuals develop problem-solving skills that help reduce pain and the psychological distress from pain. It really emphasizes the language that we use and the relationship between the pain, thoughts, and emotions, as well as behaviors, and focuses on cognitive restructuring. Acceptance commitment therapy, on the other hand, really focuses on acceptance of the pain. being aware of what you're doing in the present moment, and recognizing that one can separate the experience of suffering from pain, so that you have, even though you recognize that the pain absence may not be feasible, suffering is reduced and relieved, that you're not in as much distress about that pain. Supplements, not a whole lot of data to back this up, none in HS, sparse in other chronic diseases, but may be used by a lot of medical providers in helping patients find safe management strategies for their pain. Some supplements that may be used are low-dose naltrexone. This is it helps increase your opioids on the inside, your endogenous opioids. But if you're taking opioids or narcotic medicines at the same time, it can really blunt the effects of those medicines. Low-dose naltrexone is something that has to be compounded and typically is prescribed by a medical provider. Alpha lipoic acid, turmeric, cherry juice extract, boswellia, and even ginger. And these have been purported to have different benefits. So ginger reportedly is anti-inflammatory and reduces nausea. Turmeric, similarly anti-inflammatory. And alpha lipoic acid has been shown to be particularly helpful with neuropathic pain. All right, great. So now we are armed with the language that we need to describe our pain, thinking about the chronicity, know a little bit about some of the management options in terms of medication, psychological therapies, procedures. So where do you start? Where should you look for help? And oftentimes starting with a primary care doctor or a dermatologist and saying, just recognizing this is a problem. Hey, pain is a problem for me. It's affecting my life in these ways. You know, I can't drive my car, or I can't cook dinner for my family. But there may be a time at which it becomes apparent that maybe the primary dermatologist or the primary care provider doesn't have all of the tools that are needed to help you have effective pain management. And so some of the other provider types that you may want to ask and get help with are a pain specialist. A pain specialist is someone who's gone through medical school, a physician, and specializes in evaluating, diagnosing, and treating pain. So these are providers who really can focus on pain, and they can prescribe medications as well as do procedures for pain. They may not have a lot of HS specific knowledge. And this is where a multidisciplinary approach can really come in to kind of bridge your dermatologist with your pain management specialist so that there's some communication. Pain psychologists may be helpful. Pain psychologists typically have gone to psychology school, have a PhD or a PsyD, and they focus on how thoughts and emotions can influence our pain perception. And this may be particularly helpful for people who know that they have anxiety or underlying depression and may not realize the ways in which that kind of intertwines with the pain experience and the suffering experienced from pain. Physical medicine and rehab specialists. These are also physicians, and they typically work to try to restore function for a person who has been disabled by a disease or a disorder. And then palliative care specialists, and you can see in my slide credit that I'm crediting Dr. Kim Kursine for the content of a number of these slides. She's the palliative care specialist who I work with at Emory and is fantastic. Palliative care specialists are physicians who try to help people who are living with a serious illness. They try to help relieve the symptoms and the stress of living with that illness for both the patient and their loved ones. They work on a team to provide an extra layer of support for patients and families. So a palliative care specialist can treat the pain, but they often take kind of a perspective of helping address the many different symptoms and causes of suffering caused by HS. So this is a breakdown of what these different types of specialists can offer. Almost all of them can prescribe medications, with the exception being a psychologist. Procedures for pain are typically most offered by pain specialists, may also be offered by physical medicine and rehab specialists. Formal psychological counseling, definitely you can get that with a psychologist. Some palliative care providers have specialty training in this, but it's not necessarily standard or something that all palliative care specialists do. Many of these provider types have an interprofessional team that is kind of integrated into their clinic and available. It's not universally the case, but particularly pain specialists and palliative care providers tend to have other specialists who are available right there in clinic. So those other providers can include things like a psychologist. Pain specialists may have a physical therapist that they refer to. Palliative care often has chaplain or spiritual support and even a social worker. Just a few notes that it's important as you're planning who you want to go to, that you Brent, you are unmuted.
Sorry about that.
No worries, no worries. Thanks. It's important as you're kind of planning who you want to see to think about insurance coverage. This can particularly be an issue for office visits with psychologists, not always covered, and then also medication coverage. All right, so you've picked out what kind of specialists you need. You've got you're armed with your information about your own pain and your disease process. How can you begin to prepare for the appointment? I think a lot of this is about thinking about what you want to accomplish. What are your expectations? What are the aspects of your pain that you want the most help with? Is it acute pain, chronic pain, both? Is there anything that you are not willing to consider? Any kind of treatments that are totally off the table? And that may affect also who you decide to see. Are you open to procedures for pain? Are you willing to address the emotional aspects of pain? And then do you feel like you can effectively advocate for yourself? If not, it may make sense to have someone go with you to that appointment to help you talk about this and to be a support for you as you advocate for your own pain management. What kind of expectations can one have when going into a pain specialty appointment? I think that there's a mutual goal between most providers as well as the person seeking care to try to manage the pain to allow for acceptable quality of life and function. Unfortunately, being pain-free is not always a realistic goal or expectation, partially because the medications that we use to treat pain have risks or side effects when they get to the point of complete pain mitigation. And also because our treatments for HS itself are not perfect. Anyone who sees a provider for their pain deserves to be treated in a respectful manner. And I've heard and I know that there's a lot of structural racism and implicit bias and all kinds of issues built into both the system and individual healthcare providers. But my recommendation would be that if you don't feel that you're receiving respectful care, to try to find a provider who you can really develop a therapeutic relationship with. And that may take time. Finding the acceptable and a management strategy for your pain that is acceptable to you, that has minimal side effects and improves that quality of life may take some time and some work. And then also your pain level and character may change over time, despite your best efforts and the best efforts of your provider to help you manage it. So thank you for listening and getting through this far. These are kind of the take-home points that I want people to walk away with. HS causes pain, and that pain greatly impacts quality of life and emotional health for people living with HS. HS patients experience many barriers to effective pain management, and advocates are working to try to expand the treatments that are available for effective pain management and to help educate other healthcare providers. Understanding your own HS pain and treatment options can help you have more control over your own healthcare. And that's really the goal of this talk, to arm you with information so that you have more control. And finally, even over-the-counter medications can be unsafe if used in very high doses or for too long. So always be sure to talk about those over-the-counter medications with your medical providers. So thank you so much to the HS Foundation for putting together this series of lectures and for inviting me to participate. Thank you also to my mentors and colleagues, research team, and to all of you for being here tonight.
And thank you so much, Dr. Orenstein. That was wonderful. And it's so great to see the wonderful work you're doing to help us better understand pain and HS and what we can do about pain. If anyone has questions, there's a Q&A button at the bottom that you can push to post things, or you can post them in the chat. One of the questions that came to us from someone was, how is pain management different in patients who haven't been able to get their disease under control with medications?
So I think most everyone lives on a spectrum of having their disease under control and not under control. And I suppose that my advice for that would be that we should be pursuing both in parallel. We should be pursuing disease management, but we shouldn't be waiting on disease control and disease management before we address the symptom of pain, which can be very uncomfortable up until that point of better disease control. So I think that but I do think that the process of getting pain management under control and the types of medications are probably similar between the two groups, with those who have their disease under control just needing less of it.
Excellent, excellent. And then our second question comes from Rita Pichardo. Hi, Rita. How are you? Haven't seen you in a while. Miss you. And she said, excellent lecture, Dr. Orenstein. What is your opinion about acupuncture and pain management in HS?
Yeah, great question. There are data to support acupuncture in other chronic painful conditions. And I think that there's probably a lot of potential for that within HS. I'm actually going to turn some of that over to Dr. Dave Louie, because he's done some work specifically in acupuncture for HS pain.
Yes, it was almost like a planted question. So we're doing a study right now for a particular type of acupuncture that is indicated for pain. So like Dr. Orenstein said, other types of pain, it's been studied. It's called battlefield acupuncture with 5 little spots on the ear. So we're in the middle of a study now to see if that could be a good option, because it avoids a lot of the side effects we worry about with other treatments. So if it ends up working well, it could be really great, but we're still in the midst of it and we don't have the data yet, but I'm hopeful. I'm hopeful it'll be an option in the future. And then a couple of people asked if it will be recorded. We are recording the sessions and we will make them available later. So if you didn't catch everything, or if you want to share it with someone or just watch it again, we're happy to do that. And then we had another question. Our state recently legalized medical marijuana. What is your opinion of this in pain management for HS?
Yeah, so I think that there is a lot of potential, and it's not legalized in my state. I'm in Georgia. So I don't have a lot of personal experience with prescribing it for patients, but I do have patients who have registered within the state of Georgia for marijuana cards and are able to use low dose oils. And I have had a number of patients who reported that that has been very helpful for them. Oh yeah, I did have one slide on it, but I'm happy to answer more questions. It's not something that I have a lot of experience or expertise in, but I think that there's a lot of promise and certainly has less side effects than chronic opioids.
Yeah, and I think you're totally right. It's an area that we're learning more, and with the laws changing, it's allowing people to do more research, which is great because hopefully it'll kind of become more well studied. There was one question that wasn't necessarily tied to pain, but if you want to field it, I'll throw it out there. It was a kind of a two-part question. How do the COVID-19 vaccinations affect HS, and how do zinc supplements affect HS?
Sure. So I'll take a stab, and then Dr. Dave Louie, you can feel free to weigh in. One thing that we do know, there's been a big registry for patients with HS who get COVID. And one thing that we know in particular is that patients with HS who are on biologics seem to do equally well to patients who are not on biologics if they get COVID. So that's good news overall for medical management of your HS. I think your question was more about vaccines and COVID. My medical advice to my patients has been that I do recommend that they get vaccines despite their HS, because I think that we are often immunosuppressing our patients with HS to help manage their skin disease. And so I view this as an important measure to reduce the risk of getting serious illness if you do get COVID. So Dr. Dave Louie, I'll let you kind of weigh in on that, and then we can go back to zinc.
Yes. And I would echo what Dr. Orenstein said. And I would also add that if you are on an immunosuppressant, they've gotten some recommendations about how to handle getting the vaccine to make sure the vaccine still is as effective. So for a lot of the medications we use, you don't need to make any adjustment. The vaccines work just as well, but there are a few of the immunosuppressants where they might take a little break while you get the vaccine. But I would echo, it's still very important to get it, because you don't want to come down with COVID. Even though things are a lot better than they were when it first came out, it's still the safest way to protect yourself.
Yep. And then the second question was about zinc for HS. Yeah, I think that there are some data to support its use of zinc gluconate 30 milligrams 3 times a day. And I've had a number of patients, particularly those with more mild disease, who tend to respond very well in my clinical experience.
Yep. And I'd again echo that. Yeah, I find in the right patients, it's always one of the challenges with HS. Some things work great for someone, some things work great for someone else and don't work for someone. So there's a little bit of a trial and error that can be a little frustrating, but if you can kind of stick with things and have some patience, hopefully you can find a combination that works. And then we had one more question come in that says, what is the best recommendation in pain management for pits? Is there any safe topical solution, or would they cause more damage to the area with it being a widely open wound? So it sounds like when they're saying pits, they kind of mean the open areas, like open areas of skin and pain management for open areas of the skin.
Yeah, so I think that probably the systemic pain medicines, meaning the pills that people take, would be equally safe and effective for people who have open wounds. I do think your question about topicals is a good one, in that I would not recommend placing topical pain medications over large open wounds for a couple of reasons. One is that it may burn or sting when you apply it, so it may actually worsen pain. And the second being that you can get systemic absorption of some of these topical medications, which can lead to side effects. So would generally avoid putting topicals on open wounds. Lidocaine patches could be put near open wounds, but not directly over, and that may provide some relief for the local area.
Excellent. Thank you. And this one says, what would you recommend for scarring of the skin? What can help reduce the scarring?
Oh, that is such a tough question. Prevention definitely is first and foremost. Admittedly, when I have patients who are try to get the disease under control. When they're under great control, I tend to send patients to a colleague of mine as opposed to managing myself. And the types of things that I've seen my colleagues do include things like resurfacing lasers, includes things like chemical peels. But I will have to say that I'm not necessarily the expert in scar management, and I would love any insight that you have, Dr. Dave Louie.
I agree with you completely. It's a tough situation with HS and the scarring, and I'm also not a very good expert in the scar management. But like you said, I've seen laser treatments used, some of the different lasers to help kind of loosen the scars and help out with things. And then I do know that one of the ways that scars can sometimes tie into pain is that if you have surgery or even your HS is causing a lot of pain, sometimes if you aren't moving as much, the scars can actually restrict your movement. So it's good to bring that up with your doctor so that you can talk about how to address the pain so that you can have that range of motion and not lose movement in your armpit or your shoulder area from that. Or if you have lost movement, talk to them, because maybe there would be some scar treatments. But in general, we don't have a lot of great things to prevent scarring in dermatology, but we sort of have some ways to deal with it after. And then another question is, should large wounds stay moist for pain management? Wounds that reveal the pink flesh, which sometimes might be even like granulation tissue, maybe?
Yeah, that's what it sounds like. I think there are a lot of different wound care approaches, but typically I advise my patients to do the type of wound care that is most comfortable for them. And for most people, that includes moist dressings, such as things with Vaseline impregnated gauze, or even taking Vaseline like in the thickness of almost like cupcake icing and putting it on top of 4x4 gauze, and then using that as the contact layer to the skin. Because if it does dry out, you're right, removing the bandages can be very, very painful. Something else that may reduce pain with bandage dressing, even if it has dried on the skin, is to try to remove your bandages in the shower. You can get them wet first and then fully remove them. And then finally, taking a little bit of pain medicine before you change those bandages may also be helpful.
Excellent. And then another question I've been wondering, I have HS, psoriatic arthritis, and psoriasis, both autoinflammatory and autoimmune disease, and allergies run in my family. I wonder if there's any genetic autoinflammatory link. Has there been any research that suggests this?
Oh, that's a great question. There certainly have been genes that have been linked to familial cases of HS. There aren't genes that I'm aware of that link that have shown familial inheritance that are associated with the psoriasis and the psoriatic arthritis. I'm sorry that you're suffering from all of those conditions. But sometimes having those comorbidities can also mean that you have more treatment options available to you compared to someone with just HS. It's often easier to get medications approved. So that's certainly something to share with your dermatologist and your treating team, even if they don't recognize it or see it right away, because that may help you get the medicines you need. Yes,
excellent point. And then one more was, can overgranulation cause an increase in pain?
I don't have any data to back this up, but certainly in my experience of patients who are healing from their HS surgeries, I've occasionally seen people who have kind of that overgranulation tissue that sticks out, and also just in the natural HS wounds, sometimes people can have those kind of beefy red overgrown granulation, like open wounds, and those can be extremely painful. If it's from a surgical wound, let your surgeon know, because they can do some things to help kind of flatten that out, whether that's prescribing creams or maybe applying something in the clinic that can help remove that granulation tissue. For the kind of those beefy red bumps that can come naturally from the inflammatory condition of HS itself, typically I see those get better with control of the overall disease process, but have not found any specific treatment that helps alleviate the pain associated with those lesions besides kind of the general pain management and control of disease. So many great questions. We have a wonderful audience.
Yes, yes. And I would say I want to thank you, Dr. Orenstein, because it also speaks to how stimulating your talk was and how much it really got people thinking about all these elements of pain and really spoke to people, which is just excellent, excellent. So I want to thank you again for your time, and more importantly, for the time you put into researching HS pain, because you are really a leader in this new field of HS pain. And I always learn from Dr. Orenstein when I hear her talk. So I'm sure everybody else learned a ton too. I want to remind everybody that there are more talks going on this week. Tomorrow, a talk for physicians, and then another one on Thursday for patients. The talks are going to be posted to the website afterwards. So if you missed any part or just want to see them again, go to the website and you'll be able to check them out. The website also has lots of useful resources for patients and providers with HS, or providers taking care of HS, patients with HS. So I want to thank everybody so much for making this HS Awareness Week a successful event. And again, big thank you to Dr. Orenstein and to the HS Foundation.
Thanks, Dr. Dave Louie. The admiration is mutual. And thanks to the HS Foundation for this great lecture series.